Good morning, everybody. I'm Cyril Gaillard from France, and I'm the founder of the training center GAT Center. And today we will discuss about ODA concept. This is my concept I developed over the year, and I try to combine aesthetic and function. And I try to keep the best part of the different schools of occlusion. So let's talk about ODA concept through a case, and I would like to introduce to you my patient. He's 40 years old, and he came into my office because he's worried about his one teeth. As we can see on these occlusal views, he lost enamel on several teeth, and some of the teeth became sensitive. So we can have this kind of when we have this kind of patient to treat. Before starting the treatment, we have to elaborate. The treatment plan, and this is the way I follow. First, we interview the patient. Then we plan the aesthetic part. After, we analyze the function and determine the new vertical dimension. And finally, we have a look at the support and biology. For the patient interview, we want to know his wishes, his needs, his limits, like maybe sometimes is surgery, sometimes is money, sometimes is time. So we need to know our patient. When it's done, the next step is to design the smile. And with the picture and the video, we design the aesthetic part. We use DSD invited by Christian Kochman. And we want to know where the tissues are supposed to be, the teeth and the perio. We measure everything and then give all the information to the lab. And the lab creates the wax-up. Just the aesthetic wax-up, no functional wax-up, just the buccal part of the teeth. And on this view, we see the addition we have to do to create the new smile. And we test this smile into the mouth of the patient with the mock-up, and we take a picture and ask the patient if he likes or not. So now the interview is done, the aesthetic part is done, we know what we have to do, and now we have to work on the function. So for the function, first question is, what is function? For me, function is two parts. We can segment the function in two parts. The first one is the position of the jaw in 6 dimensions, and the second one is the contact between the teeth. Like a plane, we can place the jaw in the space with 6 components: sagittal, vertical, transversal, and roll, yaw, and pitch. It's not only rotation and translation. The hinge axis is not physiologic. We never function with hinge axis. We talk about that later. The second part of the function is the teeth contacts. We have different kinds of equilibration in static, in mastication, incision, and finally lateral and propulsion movement. It's very clear that position of the jaw and teeth contact are two different things. Probably so sometimes we have a patient with a perfect contact and dysfunction because the position of the jaw is wrong. And sometimes we have patients with poor contacts but no symptom because the position of the jaw is correct and because the body compensates the poor contact. So about increasing vertical dimension, we have three questions. Must I increase the vertical dimension? How much should I increase the vertical dimension? And how could I increase the vertical dimension? So, first question, must I increase the vertical dimension? Why I want to increase vertical dimension? We have three reasons. The first one is to create the space for our restorations and to do minimal invasive dentistry. The second one is for aesthetic reason. And the third one is for disc reposition. So to create space, if I don't increase vertical dimension, I need to use my burr to prep the teeth and to create some place to bond my restoration. And I don't want to touch this beautiful enamel and dentin. So if I increase the vertical dimension, I create place without touching the teeth. The second question is, how much should I increase the vertical dimension? And we have literature on this. We can increase until 5 millimeters without problem. This is an article written in 2012 with a systematic review. So this is probably one of the best article. And the question is, do I increase 1, 2, 2.5, 3, 5 millimeters? How much I have to increase? And the answer depends on which material you use. If you use feldspathic, you need 2 millimeters of thickness. If you use vitroceramic, disilicate, you need 1.5. And if you use composite, it's between 1.5 and 2. So when you decide what kind of material you want to use, you decide in the same times how much you have to increase vertical dimension. Second point is depends on which support you bond. If you bond on dentin, you need more thickness than if you bond on enamel. If you bond disilicate on enamel, maybe you can have 0.8 millimeters of thickness of disilicate. But if you bond on dentin, it's better to have 1.5 millimeter of thickness of disilicate. The third question is, how could I increase the vertical dimension? The problem when we want to increase the vertical dimension is the proprioception. This is the main problem. In the literature, there are 26 definitions of centriculation and several techniques to record the centriculation. For sure, we cannot increase the vertical dimension directly on the articulator. It's not physiologic because articulator works in inch axis and not our patients. If you want to increase on the articulator the vertical dimension and place the splint or the mock-up in the mouth, you will have to touch a lot the molars on the back teeth to adjust the occlusion. So it's not something physiologic. Another thing is I don't know how my patient wears his teeth. Maybe more on the left than the right, maybe more on anterior than posterior. And if I increase the on the articulator, it will be symmetric, but it's not reality. Regardless of the school of occlusion, we all look for a balanced position and reference position. The balanced position is an harmony between the teeth, the muscles, and the TMG. And this harmony is controlled by the brain, and most exactly the brain controls the muscles, and the muscles place the jaw in the space. In the docent's book, we can read that the muscles never lose. The problem when we want to change the occlusion is the proprioception, and the muscles are programmed by the brain through proprioception. So if we succeed to deprogram the patient, the jaw could move anterior-posteriorly, vertically, and transversely, but also the jaw could move like a plane with a pitch, roll, and yaw. This is my workflow in the clinic. So when we have asymptomatic patients, to increase vertical dimension, we use the TENS, the COIS, and the mojo. And we open the bite directly in the mouth of the patient and realize a test drive. A test drive is a splint, mock-up, or temporaries. If the patient is symptomatic, before increasing, I send the patient to the chiropractor. We will see why. And then I use the TENS, the COIS, the mojo, open the bite, test drive, and so I place my splint, mock-up, temporaries. And after this, if I need, I can work with my whole team. It's speech therapist, sleep apnea, podiatrist, orthotist, physiotherapist. All the members of this team are really, really important. And we have to check the feet, the airways, the place of the tongue, the eyes, and the muscles of the body. So it's really important to have and to create a big team, a full team around around the dentist. Why I need a chiropractor? Because there is a relation between occlusion and C1 and C2. I'm not a specialist about C1 and C2. I know that the chiropractor creates a cranovertebral angle space correct for my patient. And when this part is correct, I can record a new bite, increasing vertical dimension. The next question is, how could we deprogram the patient? I use this machine, a TENS. A TENS machine means transcutaneous electrical neurostimulation. This is not a new machine. You can find studies about the actions of the TENS, and I think today it's more than 150 universities use the TENS. But the study is for the physiotherapist a lot, because TENS is used in medicine. Each time we want to restore the metabolic activity of the muscles, medicine physiotherapists use the TENS, but it's more rare in dentistry. The action and indication of the TENS, muscle relaxation occurs due to increase blood flow, and toxin and lactic acid are released from the muscle in spasm, and they become saturated with oxygen and ATP. So the anaerobic metabolic process turns into an effective aerobic metabolic process. The relaxed muscles restore their normal legs and move their lower jaw onto a physiologic position. We just have to place some pads near the condyle where the nerve number 5 goes through, and turn on the machine. And during 1 hour, as you can see, the patient's jaw moves under the electrical impulses. So 1 hour on TENS, and after this, so to relax the muscles, I use the TENS, and to stabilize the jaw and to simplify the bite registration, I use the COIS appliance. So we can did it with digital and print or mill, or also we can make it with acrylic resin. And in the mouth of the patient, we just have one contact between the lower incisor and the COIS. And the question is the thickness of the COIS. The thickness of the COIS depends on your aesthetic analysis and the materials you want to use on the posteriors. So you adjust the COIS until for the aesthetic it's correct, and for your materials it's also correct to have space to do minimal invasive dentistry. So come back to the patient. We have our patient and we use the TENS, so he relaxes for 1 hour, and after 1 hour I place the COIS in the mouth and we ask the patient open and close, and we have reproducibility. And this is so important to have reproducibility at this time. Then to record the bite, I place some silicone on the back, ask the patient to bite, to close on the COIS, and it's done. So the TENS gives me sagittal, transversal, roll, yaw, and pitch, and the COIS gives me vertical. One thing, be careful when you record, because the posture of the patient is really important. If the patient's lying down, the position of the jaw will be different than if the patient is standing. So it's important when you record the bite to have the patient standing straight. Same thing with the head position. If the patient have the head forward and bite, the position of the jaw and the contact will be different than if the patient tilts the head back and bite. So be careful with the posture of the patient, be careful with the posture of the head. Another thing is be careful with the tongue position. If the patient, make an exercise, place your tip of your tongue on the palatal surface of your premolar on the right and bite, and you have some contact. And now place your tip of your tongue on the palatal surface of premolar on the left and bite, and this is another jaw position. So we have to ask to the patient to place the tip of the tongue just behind the central incisors. And the last thing is be careful with the eyes of the patient. I ask my patient to close their eyes, because if not, he look at you all the time and move the head and try to help you to work, but move your head, move his head, and the posture of the head is really important to have a straight body and head posture. So now everything before the tense, the coils was for static position, the position of the jaw. But what about dynamic? Because life is dynamic. For dynamic, I use a mojo. What is a mojo? Mojo is like as a camera, and look at the video. The patient will open and bite. Yes, he's opening, bite, and we can see on the screen the same thing. And we can record all the movement, the physiologic movement of the patient. This is something crazy, because with that, we're able in the lab to create splint, wax-up, temporaries, final restoration with a real articulator of the patient, not a virtual articulator, but with the patient. So what we can record with the mojo is everything. Open big, bite. Also, we can record mastication. This is a cycle of mastication. And it's so important to create teeth in relation with the mastication, the cycle of mastication of the patient. And also, we can record the position of the jaw on the coils. So this is open and bite on the coils. You see space between the teeth. This is because the patient bite on the coils. And I can measure on this part if I have enough space to create my restoration. And if not, I can open the vertical dimension. I can increase the vertical dimension directly in the mojo. Why? Because this is my patient. This is the same thing. If I increase vertical dimension on the mouth of my patient, or if I increase the vertical dimension on this record in the mojo, this is the same thing. So if I make a mistake, I can increase vertical dimension in the mojo. And also I can I can transfer the cycle of mastication on the laboratory in ExoCAD, and when my lab creates the final restoration, it creates the final restoration with the cycle of mastication. So it creates something really functional. So, next question. How can I test the new occlusion? So remember, at the beginning, I create aesthetic wax-up. This is the aesthetic wax-up. I record static and dynamic of the patient with the TENS, the coils, and the mojo. And also, if I need, I use my team with the chiropractor, speech therapist, sleep apnea doctor, physiotherapist, orthoptist, podiatrics. And I create the full mock-up, the full wax-up, and I create the full mock-up in clinic. So I place some etching because I want my patient keeps the mock-up for 2 months. And this is a mock-up, and this is equilibration. And now this is equilibration. Equilibration, remember, this is 3 things. This is equilibration in static, in mastication, and laterality propulsion. So, in static, this is a kind of contact I want to create, just cuspid force and very small contact. I don't like a surface of occlusion. I just want some point. So this is in static. And for mastication, mastication is something very special. Mastication is different than canine function. If you want to see this video, you will see mastication, and we have a contact on the molars, premolars, and canine. This is mastication. But if the patient does canine function, so this is mastication in the opposite part, so we can see the trajectory on the molars, premolars, and canine. And when the patient does canine function, it's something different. This is incision. So, what kind of trajectory we want to have? This is the green arrow. The green arrows show the trajectory of mastication on the teeth, and these are the contacts we want to obtain. It's not interference. So all this trajectory on this part, this one, and this one. This is a good trajectories. This is mastication. We want to create that. And more we have trajectory on this, more the patient is comfortable. So this is mastication, and the last part is laterality. So for the patient, this is the contact we obtain, and for mastication, this is a video for equilibration of the mastication. So we place occlusion paper thick enough, 200 microns, and the patient chews the paper. So it chews, it's not bite, it chews. And we want to find a trajectory of mastication on each teeth from canine to the second molars. If we don't find the trajectories, we add some composite on the mock-up like this. So we place some flowable composite. We make some polymerization. So we can see a trajectory on canine and premolars that's pretty good. And now again, place the paper, ask the patient to chew. So the movement is from outside to inside. Look at the movement of the jaw. And now it's better on the molars, maybe a little bit too much, and we remove a little bit composite. And so this is how we have to equilibrate mastication. But since I work with a mojo, I have less and less equilibration in mastication because I create a perfect anatomy of the occlusal surface of the molars and premolars with the mojo because I record the mastication. So again, we equilibrate in static, mastication, laterality, so it's validated, and we validated the aesthetic part with a video and a picture of the face. And for 2 months, the patient stay like this, and we just record some mastication, and we equilibrate the patient perfectly with the mojo. Also with the mojo, this is a video from Maxime Jason. This is the creator of the mojo. Also, we can record the speech. It's really important when the patient say 60, 61, 62, 63 until 70, and we can see how the jaw move and how your lower teeth can touch your restoration. Same thing when it's the final restoration. So after 2 months, this is time for preparation and to finish the case. So we prep, I will go very fast. We prep through the mock-up and record the bite step by step to keep the position of the jaw. We can record, we can take an impression with a digital impression, and also we can take impression of the mock-up, and we can superpose the two impressions, prep and mock-up, and like this. The lab can perfectly copy the form, the shape of the mock-up for our final restoration. And another thing is it creates the final restoration with also the mojo. And again, we have the cycle of mastication. This is not a virtual articulator again. This is our patient. This is the reality. This is the virtual reality. This is amazing. Mojo is amazing. So after this, the lab mill all the ceramic, and this is milling and painted ceramic, Emax and Impress. And this is a bonding time, very fast, the trying, place the rubber dam, look at the adjustment, it's just amazing. And this is the restoration after maybe 1 week after the bonding. And this is the smile of the patient, sorry. This is the smile of the patient, and the smile of the patient with the face. And that's it. It was a treatment. So, thank you so much for your kind attention. If you have any question, I can ask and I can answer by email, or on Facebook, Instagram, or LinkedIn, and YouTube. Thank you so much. Take care, guys, and see you later. Bye.